hyperglycemia by inducing insulin resistance. These are all the alterations of the inter-organ communication in obesity with reference to leptin, neuropeptide Y, adiponectin, fibroblast growth factor, asparagine. And we have the methionine-liking protein 4, GLP-1, interleukins, as well as myostatin. Next is alterations of inter-organ communication in non-alkyl fatty liver disease, of course enumerated by our gastroenterologists. These are all the contributing and modulating factors, and these are all the pathophysiological changes that occur inside the hepatocytes, ultimately resulting in inflammation, oxidative stress, and inflammation activation, resulting in fibrosis, hepatocellular injury, stellate cell activation, and fibrogenesis. Next is alterations of inter-organ communication in atherosclerosis. These are the contributing factors and modulating factors, ultimately resulting in the genesis of the atheromatous plaque through the deposition of LDL particles and the activation of the various immune cells. So, infiltration of atherogenic lipoprotein, additions of blood leukocytes, migration of monocytes, extensive proliferation, and collagen synthesis. Next is inter-organ crosstalk contributing to beta cell dysfunction. So, inter-organ crosstalk involved in beta cell failure, we have the hepatokines, we have the myokines, we have the bad kines, right. So, adiponectin have protective effects on beta cells. Leptin impacts beta cell function, and this free fatty acids spill over from adipose tissue, induces insulin resistance. Skeletal muscle and liver might exert detrimental effects on beta cell function. And intra-amyloid polypeptide, they promote inflammatory response through promotion of interleukin 1 beta. So, obesity and type 2. Obesity, it refers to chronic inflammatory state, including type 2 diabetes, and that this inflammation have an impact on the progressive development of beta cell failure. In response to glucolipotoxic environment, beta cell also releases certain pro-inflammatory factors along with the inflammatory cells like macrophages and immune cells, which can also causes the release of various chemokines and cytokines. These chemokines, in the presence of lipid level, also forces the beta cells to produce islet amyloid polypeptide, and this results in progressive failure of the beta cell function. Next is exocrine and endocrine crosstalk. Chronic pancreatitis, cystic fibrosis, they are associated with islet dysfunction and diabetes due to injury, inflammation, and fibrosis in the acini. Inside the islets, with reference to the pancreatic ductal adenocarcinoma, the beta cells are dedifferentiated in patients with the pancreatic ductal adenocarcinoma. What causes beta cell dysfunction? So, we have glucotoxicity, lipotoxicity, inflammation, oxidative stress, altered gene expression. So, the beta cell compensation and dysfunction in Met syndrome. Early stage is characterized by hyperinsulinemia in insulin resistant. That clearly shows the beta cell ability to secrete enough insulin. Over time, in a subset of patients with type 2 diabetes, that develop beta cell dysfunction. And this dysfunction of beta cell is characterized by endoplasmic reticulum stress, mitochondrial dysfunction, giving rise to either beta cell apoptosis or dedifferentiation or transdifferentiation or altered beta cell mass, and with a characteristic loss of failure of the beta cell function. So, we have the mRNA as well as long non-coding RNA. They also play an important role in beta cell dedifferentiation, beta cell loss, and dysfunction. Next is beta cell differentiation definition. Loss of mature differentiated beta cell features primarily associated with insulin secretion. It refers to beta cell degranulation. In fact, the beta cell identity is tightly regulated by many essential transcription factors. This adoption of the dedifferentiated phenotype is a protective mechanism to support beta cell survival under conditions of stress and is reversible under specific conditions. And we have the transdifferentiation, there is direct conversion of terminally differentiated cells into other cell types. Alpha and beta cells, duct cells into beta cells, eosinophils into beta cells, and hepatocytes into beta cells. These are all the metabolic inter-organ crosstalk in the development of type 2, metabolic connections in inflammation and insulin resistance, and the evolving concept. So, hyperglycemia induces glucolipotoxicity that results in loss of insulin content and mature beta cell identity. So, loss of fully differentiated beta cell phenotype is recognized as the most likely mechanism underlying type 2 diabetes, and several work has identified markers of dedifferentiation in the islets of patients with type 2. So overall conclusion, numerous extrinsic pathways and intrinsic mediators underlie reduced beta cell function and reduced beta cell mass. So in the presence of insulin resistance under glucolipotoxic condition, various extracellular signals from various organs modulate cellular responses. From such a viewpoint, inter-organ regulation may play a causative role in the type 2 diabetes, at least in part, by modulating the process that render beta cells unable to respond to increased metabolic demand. So if you look into the 2-pound coin, you can see what is written on it. Standing on the shoulders of giants. Today I am standing before you because of my doctor friends from Teacher Diabetes Specialty Center, IMA, Diabetes Club of Tiruchirappalli, RSSD National Tamil Nadu Chapter, Metabolic Club of Kumbakonam, Diabetes Club of Dindikal, Tanjore, Madurai, AP Tamil Nadu Chapter, Trichy and Madurai chapters. So thank you very much for your kind listening and patience.
Thank you very much, sir, for a wonderful presentation. Real oration, really we enjoyed the latest update on the beta cell hormones, inter-organ talk and cross-talk. A great presentation. Really, we owe to you. It's a wonderful presentation. Thank you very much. Since it is an oration, there is no questions allowed. Welcome.
Thank you so much.
Sir.
Thanks a lot.
Thank you, sir.
Thank you, sir. We will now move forward to one of the highlights of our conference, which is the reverse panel. Our esteemed panelists, moderator and discussants all bring a unique perspective to the table and will be discussing in depth about managing diabetes in the young. With that, I'd like to welcome Professor Dr. S. Venkataraman, who will be our moderator. Sir is a senior consultant diabetologist at Apollo Hospitals, Chennai, as well as at Surya Hospital. He has authored books. He has contributed chapters in the Handbook of Diabetes and on peripheral vascular disease in the Textbook of Diabetes edited by Dr. Senani. He has received the International Diabetes Federation Award for his paper on pregnancy and diabetes at Washington and the Lifetime Achievement Award by the Indian Medical Association. Sir, we welcome you.
Dr. R. Madhavan sir. He is a professor of diabetology, Dr. Ambedkar Institution of Diabetology, Government Kilpak Medical College. He has 38 years of teaching experience of UG and PG Medical College. Sir, we welcome you, sir. Also, would like to welcome Dr. G. Vijay Kumar sir. He is a diabetologist, Apollo Specialist Hospital, Diabetologist Medical Care Center. Sir, we welcome you, sir.
Also have two discussants today. Dr. R.P. Rajesh, he's a consultant diabetologist at Ardhavan Diabetes and Research Center, as well as at Deepam MedFirst Hospital and the HVF Hospital of the Ministry of Defense, Avadi. He has formed the Chennai Diabetes Forum, through which various CMEs are conducted in diabetology. He is involved as a faculty and as a part of organizing committees in multiple conferences and as part of certificate courses. Sir, we welcome you. Graduate teaching programs. Sorry, sir. About Dr. Major Gauri Shankar. Sir has served in the Indian Army between 2003 and 2008 and is decorated with 4 medals. He is a member of various societies including the API, RSSDI and the ISA. He is passionate to learn, talk, travel, teach, cook and photograph people. Sir, we are honored to have you with us.
Glory. Sir. It's a pleasure to be. Thank you, sir. Start. So, good morning, bar afternoon, friends. It's 12 o'clock. I think that was a very fluent oration by, as expected by my friend Velu, Shanmuga Velu. In fact, Velu and I have been undergraduate students, separated by just a year in the undergraduation and then probably in the same batch in the post-graduation. So always interested in the theoretical aspects of medicine, especially diabetes. So it was just a good revision and excellent exposure of the relevant science. Now, I think continuing from where he started, I think Professor V.T. Balraman was always good in Tamil, especially Tirukural. And I came from Hindu school. Our school slogan was Karka Kasadara Karpavi Katrapi Nirka Dirkataha. Whatever you learn, learn without blemish, and having learned without blemish, try to practice it. I think that is the motto of many scientific programs, especially the DClub, which I think my friends have started more than about a year back, I mean a decade back, and doing human service with respect to dissemination of knowledge, and I'm happy to be part of many of your activities, or almost all your activities, and really, what shall we say, pleasant to realize the growth and see the growth that DClub has taken with respect to dissemination of science. Thank you, Dr. Natarajan, Dhanmitran, Parandaman, and Mohan, for all the affection that you have and also the respect that you have, and then the eagerness with which you want to learn and then disseminate. I think that's one of the aspects of medicine, which is the eagerness and the perfection with which you want to learn it and then share that knowledge with your colleagues, students, and friends. I think that is the purpose of this particular meeting as well, as I have seen it. Wonderful deliberations. Now, when it comes to the topic of discussion today, I think in diabetes, always the challenges are in management. In fact, if you have a, what shall we say, a debate or even a plenary lecture, I don't think many of us will see eye to eye on whatever has been translated, because this gives scope, tremendous scope for coupling your theoretical knowledge with your own practical experience. So, management of diabetes is always a problem. Of course, the guidelines, consensus guidelines are there, but the individual clinician has got his own prioritization of the molecules or the target that he has in mind, which is not far away from the evidence-based medicine. So this is with respect to management. Quite often, since we deal with most of the diabetic subjects who are type 2 diabetic subjects, diagnosis is not always a challenge. The challenge is always a management, identifying the comorbid conditions and then other aspects. Now, there are a subset of patients wherein diagnosis is a challenge. And that is the purpose of today's discussion. So, when an 18-year-old or 20-year-old or 25-year-old girl or boy, with or without obesity, presents with a high blood sugar level, I think basically with the clinical presentation, with your knowledge, you should have a comfortable level of confidence to make a clinical diagnosis and then substantiate with the relevant guidelines. I think the purpose of today's discussion with my learned friends, Professor Madhavan, Professor Anand Moses unfortunately couldn't be here to share his thoughts with you, and Dr. GVK, and of course ably assisted by my friends Dr. Rajesh and Gauri Shankar, is to present about 3 clinical cases. And what I want to share with you is, ladies and gentlemen, these are all real-time cases. These are all real-time cases as has been captured. So not necessarily the presenters, Rajesh and Gauri, has been involved in the treatment of these. Many healthcare providers have been involved. Reputed diabetic institutions, reputed diabetologists, endocrinologists. So what I'm trying to say is, it has been presented in such a way that what has happened. Now it is up to us, my 2 panelists, my great friends who have got enormous knowledge and experience, and of course, wherever is, I mean, whatever I feel, I'll also give my inputs, filling the absence of Professor Anand Moses. So the purpose is to go through these cases so that we have some clarity with respect to establishing a diagnosis in a young diabetic. So without wasting much time, I think the diabetes in the young So this is a reverse panel. In other words, the case will be presented slide by slide. I think we are going to give our thoughts. Then possibly what has happened in the real scenario, maybe time permitting, we'll have some audience participation also if my fellow panelists, Professor Madhavan and Dr. G.V.K. decide. Now I request Dr. Rajesh and Gauri to occupy, and once again thank for the excellent spade work. Whenever we do a program, always these two are behind us to guide us academically, and so is this program as well. Thank you, Rajesh.
Thank you, sir. So I would like to thank the entire team for involving us in this program. I'd like to thank the opportunity given by Venkatraman sir, Madhavan sir and Vijay Kumar sir. What we are going to do in next, say, 55 minutes is, we are going to present 3 cases. As sir said, it is very, very raw. It is the same case which we had seen in our practice. We try to keep it as naive as possible, so that we have done mistakes. We have done mistakes in understanding. So as we discuss, we will let us explore the mistakes that has been done and learn from these mistakes and make a proper diagnosis. That is the objective of this program. It is going to be challenging because it's a young people, so there will be lots of diagnostic dilemmas. That is what we are going to decipher. It is not going to be a question and answer session or an interview. We are going to present the case and we will discuss it with our teachers, like what we could have done better to improve the outcome in improving the understanding of these patients. That is the objective of this program. So with this, I would like my friend Dr. Rajesh, can you just go with the
Yeah, I'm absolutely ready. So before I could start, I want to, a very good afternoon to all of you. Let me profusely thank our Professor Venkatraman sir for giving this opportunity, and also thank the organizers of DClub for giving this opportunity. And we have eminent seniors here, so where they are going, your knowledge and inputs on this case are going to be really precious, and we are eagerly waiting to gain knowledge from you regarding this case. So with this, let me straight away go into this case. So here, you have a very young patient, 18-year-old girl, Akshu. If you look into the BMI, it is 19.5. Obviously, it is not obese. As per the Indian standards, you can say it is normal also. Otherwise, definitely not obese. You can see it is 19.5 only. And she comes to us with a history of recurrent vaginitis. So this is the presenting complaints, recurrent vaginitis. So obviously, when somebody has genital infections, what we do, you usually do a random blood sugar, and there you can see it was 380 there, and the patient was surprised and shocked. She told, why is this so very high for me? Last year only I took a lot of sweets when I was preparing for my examination. Why is it so very high? She was a little confused. So then we looked into what was the HbA1c. You can see it was 12.8. Otherwise, she did not have any symptoms of diabetes, any classical symptoms, like she did not have, this was her usual weight. She did not lose any weight. There was no polyuria, polydipsia, all the classical symptoms of diabetes was not there, and absolutely asymptomatic. And we also did ketone there, and ketone was negative for this patient. So you want anything to add up here, Dr. Gauri?
So, fine. This is the presenting case. Like the fundamental thing as this patient presents to us in our practice is, first she is an 18-year-old, BMI is about 19.5, and no features suggestive of insulin resistance. So these 3 points presenting early with as Dr. Rajesh said, a normal BMI and no features of insulin resistance. She didn't have any viral what, acanthosis, she was not obese, her tummy was normal. So everything was normal. So are we looking at a type 1 over here, or her blood sugar is about 380 plus, HbA1c is about 12.8, and she is presenting with a history of recurrent vaginitis. So in spite of recurrent vaginitis, she is not going for any ketones positive. So as you see, like ketones are negative. So am I handling a type 2? So this is the fundamental question I want to understand from this case, whether it is a type 1 or type 2, sir.
Yeah, very interesting. Normal BMI, that is Indian standard is 21. Normal BMI, 18-year-old. But the most important thing is without ketone, and if you can see the random blood sugar is 3 at HbA1c 12.8, which is very, very, alarmingly high. Now, in this situation, there are no features of insulin resistance, that is number one, and no ketones are also
And
there.
menstrual cycles are also normal.
And I mean, if you think about type 1 diabetic, you know that most of the type 1 diabetes, I don't think they'll present as vulvovaginitis, but they come with more of a gross weight loss which they come. Usually if you see the type 1 diabetes, generally you can see that hardly they present with vulvovaginitis. I think this is the one which you need to think about, whether it is type 1, unlikely could be type 1 diabetic because of this.
What I feel is that, as Dr. Venkatraman was telling us in his introductory remark, in 90% of the cases, subjects, at presentation, it is not very difficult to arrive at the type of diagnosis. A good clinical history is what you require. You talk to the patient for 5 minutes.
So,
you'll
so,
know
so
what
in
type
this
of
context,
diabetes
what kind of a history or what kind of a physical examination can be helpful for us to favor a diagnosis of either type 1 or type 2?
The most important thing I would like to ask is the mode of onset, whether it is an explosive onset or insidious onset. That is very important. That will give you a clue whether it is a type 1 diabetes or some other type of diabetes. Family history. There is nothing about family history here. Whether any of our relatives, blood relatives, were diabetic, and if there was a vertical transmission in 3 generations, that will give you a clue that it may be a, for instance, a Modi type of diabetes. So I think these 2 things are very important. That is not there. And I understand this is the presentation. When the patient came to you, that was the first time diagnosed with diabetes.
Sir, when we poked the history, she gave one important positive history that she presented with this recurrent vaginitis. When we asked like what was happening the last time, she gave a history of last time also when I presented like this, the doctor did the investigation, the blood sugar was 300 and 400 plus. I thought that it is all because of the chocolates that I was consuming during JE preparation. I didn't give much importance. So for about 1 year.
No, what would I like to know is, was she told that she has diabetes and treated? That's very important.
She didn't.
So
she said that sugar was so much last year also when I presented with this complaint.
Well, almost 1 year she didn't bother about.
She didn't.
Oh, okay. No history of hospitalization with acute
No history of
metabolic
hospitalization, no
decompensation.
management. She didn't see any doctor for her sugars.
So all this history militates against type 1 diabetes. So it's very unlikely to be type 1 diabetes. A type 1 diabetic patient doesn't remain for 1 year with 400 and 500 without metabolic decompensation, ketosis, and at least 1 or 2 admissions. I think we have to look for other types of diabetes in this case.
Sir,
I
with
think
respect,
I think Dr. Madhavan is thinking about family history. It's a very, very important question he has raised. Usually a 3-generation transmission, it can be a Modi. But you know, Modi at the 18 years, is it likely to not to be there, Modi also? I think that's an aspect. Usually it's around 20 to 25 years Modi. But 18 years, that is 17 years. She is now 18 and she has got the symptoms for 1 year. Though the onset of diabetes seems to be around 17 years old, which also negates the possibility of Modi. And how about the family history? He's got any 3-generation transmission history?
Sir,
subsequently
we will discuss about that, sir.
Okay.
Now,
sir, apart from the family history, do you think menstrual history has a role here to arrive at a diagnosis? Suppose if this patient has irregular
If you are
menstruation,
thinking in terms of polycystic
PCOS, something like that, could it favor
without that history, I don't think menstrual history is going to give any clue about the type of diabetes.
okay, sir.
And one more thing is that when you talk about it, this is a very important case actually, you know, I mean for discussion purpose. Suppose if it's a type 1 diabetes, most often type 1 diabetes happens around menarche, around 13, 14, 12, 13, 14. At least in India, what we found in VHS medical centers is a huge rise during menarche, generally. And sometimes also we found that in June and December, where these usually viral infections can happen, at that time also it can happen. Just for the information sake, what happens in India as far as type 1 diabetes is concerned.
But also, I think Dr. Venkatraman will agree, we always used to talk about a special category of type 1 diabetes in India, slow onset type 1 diabetes. The destruction of beta cell is not complete at the first instance. It's a very slow process. So initially they may not have the explosive onset. That is very common in India. We have seen many number of cases. So this case, if you take that into consideration, still possible that this is a type 1 diabetes.
Sir, so with this ambiguity lying over
I
there,
add one point, Gauri.
Sir.
I think again for the audience I want to tell, this is a real-time case. So that's why the discussion has been, had it been also. See, if you had a simulated case, we would have changed the BMI and we would have added something. This was exactly, so a case like this, I think in the clinical parlance, when this patient first presents, you always make a diagnosis of query type 1 diabetes. Yes, ketones are negative, and she has been without treatment for 1 year. No, she is not going for metabolic decompensation. Yeah, those are points, but still you should have a working diagnosis at this stage. So it will be a query type 1 diabetes, and you will initiate the patient on insulin. History-wise, as has been, yes, family history of diabetes. For example, this patient, had she had acanthosis nigricans, had she been obese, had she had PCOD, then certainly you would have had features of insulin resistance. Your diagnostic tilt will be towards a younger onset type 2 diabetes mellitus. If we did not have all those things, so still at this stage, you can always say a query type 1 diabetes, maybe just for theoretical consideration, any history of a viral fever preceding the onset of symptoms, but that becomes meaningless because the patient has been without treatment for 1 to 1.5 years and still she has not lost much. I think MODI you can have. See, classically when we say 25-year cutoff, that is a cutoff. I have had cases of MODI, suspected MODI, MODI 4, H1F1 alpha. In fact, she was on insulin, young girl whom I saw in SMF. I think Samukanna will remember it. So that girl was related to one of her friends, Dr. Jaya Subramaniam. Now she should be around 40 years old. I started her on insulin. Subsequently, she was on OHE. Of course, she got married at that time. What I'm trying to say is, this is an age group wherein lot of diagnostic possibilities exist. So at this stage, I think the diagnosis should be.
Sir,
yes.
One point, sir, I need also clarification from you. If it's a MODI, do you think that they will be so explosive? MODI usually will not be having HbA1c of 12.8 and 380. So it's unlikely because of.
There are various types of MODI, as I think we discussed in the previous also. See, the glucokinase deficiency is probably the mildest form of MODI, which makes its announcement only during the pregnancy. Then they are probably do not have much of a problem throughout, and there are data to suggest even they may not go in for any complications. In other words, it is a situational determined hyperglycemia warranting some treatment episodically. Whereas you have the HNF1 alpha and 4 alpha, wherein the presentation, or more importantly, the progress of the disease can be in such a way that good number of them may require insulin. Even though it is a transcription factor defect, the defect could be so severe that you may not be able to control, even though classically they are supposed to respond to sulfonylureas, they may require. In other words, the clinical spectrum of the MODI is so widely separated that it can mimic a type 1 diabetes, it can mimic a pre-diabetic, it can mimic a type 2 diabetic mellitus, and of course, and other things are just for completion's sake, the patient is young. I also look for other evidences, for example, lipodystrophy. Is there any uneven distribution of the fat or lack of fat? So these are the things. So family history, history of a viral fever, vertical descent for dominant pattern inherit, if it is available, and also the telltale evidence of insulin resistance is not there, and also other aspects which we now discuss. I think at this stage this will be, but if I see this patient with this profile, my diagnosis will be query type 1 diabetes mellitus, and of course, with the classical pattern, we'll initiate the treatment pending further points in the history and investigations.
Look for other syndromes also. In fact, there are now very rare types of diabetes. A number of types of diabetes associated with syndromes have been recognized. So young people, as Dr. Venkataraman was correctly saying, lipodystrophy is one of them. So all those things, probably history and family history is very, very important in this case.
With this provisional diagnosis of type 1, my practical question, if the patient is sitting in front of you right here, will you admit the patient or will you be treating the patient as an outpatient, sir?
No, patient is asymptomatic.
Sir, ketones are negative, asymptomatic. So, will we admit?
I won't admit, but definitely I will start the patient on insulin.
Evidence of metabolic decompensation, patient having ketonuria, breathlessness, I think this will be an indication for hospitalization, not for evaluation and stabilizing the antidiabetic treatment. Certainly, hospitalization is not warranted in this case.
So at least to remove the element of glucotoxicity, I will start our insulin. Maybe once then go back to the history and other things. And if we feel that it is not type 1 diabetes, I can always go back to oral agents.
So having decided,
the issue is that there is one more thing. Is actually even the young type 2 diabetics, where they present violently with ketonuria, and then we treat them initially with insulin, and after that we can withdraw insulin, because looking into C-peptide levels and other insulin resistance syndrome features and all. There are reported cases to state that even type 2 diabetes in the young can be present with DKA, and then they'll be reverted back to type 2 diabetes.
And, some of the Western countries have now started reporting obese type 1 diabetes. I think especially the Scandinavian countries, there was a recent article. They say obese children can develop type 1 diabetes. So that is also there. So I think it is a real challenge from what you have presented now to arrive at the correct type of diabetes at this stage. Maybe when you give more data, especially the biochemical picture, then maybe.
So obviously we require more data. So in that context, when we want to evaluate this patient, what are the diagnostic investigations which will be helpful to find out whether this patient actually fits into a type 1 or type 2, like that in this particular patient? Obviously we have to investigate this patient. What type of investigations can be helpful here, sir? Your inputs on this.
GAT65, insulin.
So you want to do autoantibodies.
Insulin assay, and also we have to do the genetic mapping for MODY. These are the three things we have to do it.
So if GAD is positive and the C-peptide, that will give you ultimately what type of diabetes the subject is having. And as he said, maybe genetic if you suspect. Now MODY is diagnosed only with genetic testing. So clinical history alone is not enough.
So to start with, apart from the usual investigations what we do, always autoantibody and C-peptide will be helpful. So you want to sum up this?
So you want to how to look at the C-peptide, sir? Why do we need to ask C-peptide? Why not ask for a serum insulin?
Because insulin levels is because you are not treated with any insulin so far. Insulin itself is sufficient. But suppose if you already put, Dr. Venkatraman was telling that I would like to put them on insulin because thinking it's type 1 query. In that case, probably we need to go for C-peptide rather than insulin assay. That's the reason I said both insulin and C-peptide assay, keeping in mind. At this, as an untreated patient, you can go for insulin assay itself. But mind you, only thing is that when the blood sugars are very high, this can have a low values, and then once after treatment, you can improve on C-peptide and insulin level. That's also we have to keep in mind.
It's necessary that to do the initial C-peptide, treat, and then again do the C-peptide.
So when the patient is presenting like this, should I ask for with the sugars of 380? Should I ask the C-peptide at that point of time, or should I come to a euglycemic stage and then ask for a C-peptide, sir?
You are thinking in terms of type 1 diabetes, I will do it at this stage,
sir.
C-peptide. Then once it is either elevated or normal, then maybe.
So the point that we should carry is like C-peptide should be followed up. Not that just because you have arrived at a C-peptide stage, you are not supposed to do 3 months later or 6 months later. Keep following C-peptide. That is a very important fundamental message. C-peptide scores over seeing serum insulin because serum insulin undergoes first pass metabolism. It gets metabolized in the liver. So you can't really pick up like how much insulin the patient secretes. C-peptide is a long-acting peptide which is there in the body for a longer period of time. So C-peptide scores over insulin at that point of time. So C-peptide has to be seen in interval. One reading will not suffice. With this understanding,
I think Gauri, why Dr. Gauri Shankar asked for should we do C-peptide at this stages, we know that in the context of type 2 diabetes, when there is a suspicion of diagnosis, glucotoxicity can impair the insulin secretion.
Correct.
So try to eliminate the glucotoxicity, bring down the blood sugar level, and then it will be much more worthwhile and meaningful to do a C-peptide so that eliminating the glucotoxicity, as Professor Madhavan rightly mentioned, I think if you are a diagnosis. So in the sequential testing, priority will be autoimmune antibodies with respect to GAD, islet cell antibodies, insulin antibodies, etc., and a C-peptide. So that will give some clue whether it is type 1 or probably at that stage. So even in the absence of antibodies, you can make a diagnosis, because if you if you're lucky enough to catch the patients early, your chances of at least having one antibody positive are high. But down the line, after 6 months, 1 year, 1.5 years, like this case, they may be negative.
So the absence of autoantibodies doesn't rule out type 1 diabetes. That is very fundamental.
Correct, sir.
After some time, it may become negative.
Higher the antibodies, the better it would be. So GAD will be present only in 90% of the patients. So we might not be seeing the other autoantibodies. There are ICA, IAA, zinc transport antibody. So higher, if the patient is positive for 2 or more antibodies, the chances of type 1 is higher. As Sir said, just because GAD negative, it doesn't mean that we have ruled out type 1 also. That is something which we again need to remember.
Yeah. So we have got the family history. You can see father had diabetes, but at a little later stage, at the age of 48 years. Otherwise, mother did not have diabetes, and autoantibodies was done. All these autoantibodies were negative for this patient, and again C-peptide was done. You can very well clearly see that C-peptide is well above the. There is a good amount of insulin production is there, so there is no doubt about it. And already we have done a ketone, which is actually negative. So with this, what can we conclude? So a young diabetic having a high blood sugar, having high HbA1c, but now with good C-peptide, autoantibody negative. So what could be the diagnosis, and what else you want to ask?
This is what we have seen after 1 year. So again, GAD is negative. She has continued to have C-peptide normal. So do we need to say that she is a lean type 2 and continue to start her on OHA? Or should we still have the suspicion of type 1 and keep her on insulin, sir? So with this phenotype.
With this C-peptide, we definitely rule out after 1 year.
Yes,
we
sir.
rule out type 1 diabetes.
Sir.
So it's very unlikely that this patient is a type 1 diabetes, or probably a very rare presentation of type 2 diabetes at a very young age. But I don't think even at this stage I will think of oral agents in a 19-year-old girl. So I'll still go for insulin at least for a short period to overcome the present scenario, and then maybe switch over to oral agents.
Absolutely.
No, absolutely. I think, and other thing is that what we need to understand is that whether it's a MODY or a type 1 diabetic, where now the type 1 diabetes has been excluded, then you have to differentiate between a MODY and a type 2 diabetic. And initially, after giving insulin, glucotoxicity, as Professor Venkataraman said, glucotoxicity comes down. I think sulfonylurea can work on both the situations. So MODY will also respond to this thing, and even type 2 diabetes, probably I will do with that. Because you can always think about metformin, but she's quite lean. That's what I was just thinking.
No evidence of any insulin resistance.
So I think at this stage, as a clinician, you can say probably it's a non-type 1 diabetes. That is from the way of labeling the diagnosis. We are just going methodically as the case has been presented to us. It's a non-type 1 diabetes mellitus. Now, if you look at the hierarchy of the classification of diabetes, it was insulin dependent, non-insulin dependent, type 1, type 2, the various syndromes, secondary diabetes, etc., etc. Now, when we talk about the classification or labeling or giving a label has got lot of prognostic as well as therapeutic implications. Now, this patient certainly requires insulin, even though she may be type 2. Okay, she is a non-type 1 because this amount of glycemic deficit cannot be captured by any OHA, right? Having started her on insulin, if you feel that the requirement is more, then probably you are justified in adding whatever OHAs you deem it as relevant in this particular case. So here I think this is not a clear-cut case, as I told you, as given in the textbooks. If the BMI were 27, you would have jumped saying this is a type 2 diabetic subject, let it bring down the body weight, anti-obesity measures, etc., etc. Here it's a normal BMI and no decompensation, no evidence of type 1 diabetes mellitus, but the blood sugar is high. So on the one hand, you have to give importance for giving a label which is in tune with the presentation, with your understanding of the knowledge, with the available clinical investigations, and then follow the patient. Second is correct the hyperglycemia. So even though it is, I think one of the questions that you asked is whether the correction of the infection will have any effect. Now, with the old school of thought, from which all of us have gained a lot, I think professor is there. So they say balanitis as well as vulvovaginitis, probably they anticipate diabetes. In other words, patients who are destined to develop type 2 diabetes mellitus, in other words, even though you cannot take it as something like a, what shall we say, as a dictum, there is an understanding that these two entities are probably solely present in the type 2 diabetic subjects, and sometimes they may even antedate the diagnosis of type 2 diabetes mellitus. Coming back to this case, a non-type 1 diabetic subject, yes, excepting for the BMI, I think probably everything is there for a young type 2 diabetic subject label to be given. But from the point of view of management, insulin plus or minus OHA.
So, no, but the last question for clarification. Now we need to have a working diagnosis. It's a very ambiguous case. So working diagnosis is either type 2.
Working diagnosis, you can say a diabetic with preserved endogenous insulin response. That's what we do. I think you have to be more pragmatic. I think it's a very good, what I thought was very apt diagnosis will be a diagnosis instead of calling type 1 or type 2 or anything at this stage. Diabetes with preserved endogenous insulin response. I think that will be a...
Down the line, can there be further reduction in the insulin secretion? And she may ultimately become either a type 1 or even we have to think of LADA. Of course, the age militates against the diagnosis of LADA, but I don't know whether we have to consider that also.
Can we, I mean it's just for the completion and discussion sake, a lean person with a high sugar, can it be a pancreatic diabetes? Can it be a pancreatic diabetes?
History-wise, there is nothing.
Most of the pancreatic diabetes may not have any steatoria. It may not be there. We need to think. That's the reason, sir, I am asking for working diagnosis, provisional diagnosis, diabetes in the young, type 2 diabetes, and MODY and pancreatic diabetes, that is type 3C, what you call type 3C. And then any other diagnostic criteria would you like to add for that?
I understand your ultrasound was done because you mentioned about PCOD. Which is normal, so ultrasound didn't show any pancreatic calculi.
Yes, sir.
So plus the fact that clinically she, of course, as you said, steatoria may not be there always, but abdominal pain and steatoria are the most important clinical criteria for diagnosing pancreatic diabetes.
No, ultrasound has been done for this.
Ultrasound was done, sir. Ultrasound normal, okay. X-ray normal.
I missed it, yeah. Okay.
So before we proceed further, I'm not too sure whether any of us mentioned it. Evaluation of thyroid function test. Sir. I think any diabetic patient, more so in the younger age group, especially with this sort of a presentation, certainly calls for the evaluating the thyroid function. And of course, as and when other antibodies are being relevant, you can always consider, but at least thyroid for T3, 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 T4 and TSH is must in the workup. Yeah, please go ahead.
So the lessons that we learned here is, as Sir said, it is a preserved beta cell is there, but autoantibody negative. It doesn't mean that on management, we have to treat her just as a type 2 with OHS. Always keep in mind that it could be MODY, but MODY was ruled out because there was no vertical transmission from the parents, since there was no parental history, both mother and father, they are educated. Father is a diabetic at 48 years.
No, that doesn't matter because we know that the successive generation, type 2 diabetes occurs earlier.
So, correct. So that we wouldn't have, actually we should suspect MODY here. So that is the lesson. And we will work up and we will let you know like whether we are able to pick those genes. But this is the final carry home message. Type 2 with OHS and insulin, and she is being treated. Now we will, as we move on to the next case, we will come to Miss Anu, 2022. She is aged 13, weighing about 48 kgs.
Can you just sum up the first case?
Sir.
So the first case, just for reiterating, it's a real case captured in the clinicals of, I think, by Gauri and Rajesh. So there are a lot of things, as I keep on repeating it, which could have been avoided, but we took it wantonly because this is the situation that you and I have. We have a textbook description of cases, but sometimes we do have cases like this. So the workup says autoimmunity negative, endogenous insulin preserved, severe hyperglycemia. You have to treat the diabetes, and then at this point of time, probably it's a normal or lean type 2 diabetic subject, but because of the hyperglycemia, you take the participation of insulin in whatever schedules you deem it appropriate for this patient, and then take the help of OHA. This is from the management point of view. Yes.
In fact, in some of the cases, we always teach students that it is not necessary to identify the type of diabetes at the first presentation. You treat the hyperglycemia, then always later you can, in some cases like this.
Sir. Yeah. So we will go to Miss Anu, who is about 13 years, 48 kgs, BMI 21. Her menstrual cycle is normal. Phenotypically, she didn't have any insulin resistance. There was no acanthosis. There was no viral tag, and HbA1c was about 11. We didn't have any C-peptide or autoantibody at that point of time. So earlier she was admitted for LRI and she was treated as type 1 DM on basal bolus therapy. All these are all previous histories. So she was requiring about 1 unit per kg of insulin, which is though it is required like slightly higher at that point of time. She has a very poor socio-economic history. Her father happened to be a daily wage, and she lost her mother in 6 months of life. So the history says, her father says she also had diabetic and she died of sudden cardiac arrest. We don't know what sort of diabetes at that point of time. The grandparent, maternal grandparent history also says that they had comorbidities, and they also died because of diabetes related complication at quite young age. That's what the father gives. Now with all these things, with the no C-peptide, no autoantibody, HbA1c of 11, no insulin resistant, a thin individual being treated as a type 1 with a basal bolus therapy. And then subsequently she was seen by an endocrinologist. So the endocrinologist did a GAD antibody. She continues to have an HbA1c of about 12 or 13 over there in 2022. And she did GAD antibody negative, and since GAD antibody was negative, she was started on metformin with sulfonylurea. So she excluded type 1 over there, and her sugars are uncontrolled. So always the HbA1c is about 12 in spite of being basal bolus therapy. So she was put on metformin and sulfonylurea along with same dose of insulin, and now there is a fair control. So with adding on metformin and sulfonylurea. So Dr. Rajesh, you want to add something over here?
Yeah, the case is very clear, but only thing what I wanted to ask, let us ask from the panelist here. So here you have a school-going kid, 13 years, having very high blood sugar, initially was considered as type 1 diabetic and started on basal bolus. Subsequently, just with GAD negative, just knowing that GAD antibody is negative, without doing a C-peptide, she was started on oral drugs. So this is the scenario now. And now after starting oral drugs, it is fair under control also, blood sugar is. So with this history alone, without doing obviously we have to investigate further, but with this history alone, with this data alone, what can we say this patient is having? Whether this patient is having a type 1, really as she was diagnosed previously, or it is a type 2 diabetes, or we have to look into some kind of MODY-like feature. What does it fit into?
And I think the age onset at 13 years will indicate itself with a HbA1c of 11 and even GAD antibody negative, still can be a type 1 diabetes because it can be a seronegative type 1 diabetes can happen. It's not that 100 out of 100 type 1 diabetics will have GAD positive. There are GAD negative type 1 diabetics are also possible. Probably I think if you have some C-peptide assays, like already patient is on insulin, probably C-peptide assays could probably give us.
But at this point of time, do you think it is
I would
a type
like
1,
to
sir?
treat it as a pure type 1 diabetic.
But once you say type 1, there is a serious concern
there is
about adding oral agents.
No, but the catch is that, but after starting oral anti-diabetics, she gained control.
No, the control may be not because of sulfonylurea, probably because of the metformin, probably.
Whatever it is, but
with
oral
she
drug,
didn't have any insulin resistance at all, sir.
No, that's what I am telling. There is no insulin resistance at
there
all.
is
As
a-
I was
Or
telling.
is she a MODY, sir?
No,
Three generation of family history.
No 3 generation. You said mother, but we do not know about the maternal.
Maternal side only.
You said
Parents
some
died of
comorbidities. You said comorbidities.
Because
but
the socio-economic history means they are from such a background that we are not able to tell the history.
capture it.
No, Gauri, even if you have a three generation transmission, the age at onset is 13 years, which will most unlikely be a MODY.
Okay, sir.
Age
Yes.
militates against MODY, but
Very
the
simple.
fact that she responded to oral agent, it is well known that many children with hyperglycemia unfortunately go on getting insulin for a long time. Until recently, we did not recognize the prevalence of MODY. Now we know that MODY is very prevalent now. So after the availability of the genetic testing very freely, I think many MODY cases are being diagnosed. But the only thing is the age, 13 years. That is very unusual for a MODY.
So
I think the importance or the clinical relevance that you give for an investigation should be very, very careful. I mean, very, what shall we say, evidence-based. Now, presence of GAD antibodies tells you there is autoimmunity going on. Absence of it in a 13-year-old individual, I don't think gives you the freedom to introduce OHAs. A 13-year-old girl, in spite of the GAD antibody being negative, yes, it is negative, still my diagnosis will be query type 1 diabetes mellitus. I think we have to combine, amalgamate the science that we have with our own clinical prioritization of the GAD, the tests that are available. So, I repeat, in a 13-year-old girl, absence of GAD antibodies, I don't think the clinician is justified in adding an OHA, especially in somebody who has got a BMI of 21, age is 13, and with a blood sugar very high, HbA1c is 11. So still it will be.
Sir.
And
So,
one more thing.
Even
Whether-
assuming
so
that this is a very rare case of type 2 or MODY,
Sir.
I think as Dr. Venkatraman was telling us, I think there absolutely no indication for all ages.
Sir,
The 13-year-old.
so after 1 year we are saying, sir, you can complete.
No, after 1 year, I think, how do you say that before coming, according to the history that they said, initially they were not under good control, after adding OHA is under good
Sir,
control.
that was the time, sir, 12.7.
No, but 13.7 to 11 and again 12.7.
No, sir, no.
After that, HbA1c was not done.
After
Blood
that,
sugars
we
came down.
started her on, so August 22, we did the GAD antibody. And then after December 12, 22, since the HbA1c was not getting control, she was seen by the endocrinologist and was started on metformin with sulfonylurea. We did a CGMS over there. In 23, CGMS showed that it was all getting settled.
No, but basal bolus therapy was also
Basal
going
bolus
on.
was continued.
No. After coming to you, did you give a proper delivery of the insulin?
Escalate the dose.
Escalating the dose, number one. Number two, proper, whether she was taking proper, see, motivation. A child with a type 1 diabetes taking basal bolus therapy requires a lot of education about not missing the dose and taking the insulin and appropriate way of taking insulin. I think you could have done that, and that could be the reason for
sir,
good control.
I didn't see that patient at that point of time, sir. I saw after seeing the endocrinologist. Endocrinologist already started her with these parameters and with GAD negative. She started on metformin and sulfonylurea, and she said the control is fair. I saw the patient at that point of time. But my question is, sir, so the working diagnosis should be type 1 in this patient. So if the C peptide is normal, can we allow to continue her on OHS, sir?
Now, what I thought was, had this patient been, say, 21 years, BMI is 27, certainly my priority will be to de-escalate the dose of insulin gradually with gradual addition of insulin sensitizers, obviously, especially with telltale evidence. So there I think these phenotypic features like your BMI, presence of acanthosis or PCOD, and then your other history will be suggestive of superadded insulin resistance that will go hand in hand with your GAD antibody negative for you to have a firmer diagnosis. But here again, with the younger age of 13 plus 2 years after she has seen you, plus the BMI is 21. So HbA1c being very high, all the values are in the vicinity of 11, 12 and 13. So I think all this preclude for number one, a diagnosis at this stage of type 2, and number two, for the introduction of OHS. And I think, I am sure senior clinicians are there. In cases like this, you and I have started on insulin, they have disappeared from your clinical practice and then reappear after 1 year. Somebody has started them on OHA and they are doing well. Is it not? It is not at all an anecdotal experience. We do. Yeah. At the end of these two cases, we'll have the audience participate, then we'll go to the third case. You're right. I think
I am very fond of LADA. Do you think here you will think of slow onset type 1
sir.
diabetes or LADA?
But again, age of onset
type
is
1 and a
13
half.
years.
We talk about type 1 and a half.
Sir.
so. Age of 13 years onset.
Again, I know. We always say 30 years for LADA.
30 to
But sometimes, rare instances. Or type 1 and a half. There is
So
a,
in
for
that,
type 1 type.
in that context, do we have to do any other antibodies to find out whether it is LADA or not, sir? GAD
Or
is
type 1.
I think all the other antibodies
GAD is
disappear
80%
faster.
of the cases GAD will be positive.
All the
GAD
other
60.
antibodies, they disappear faster. If at all you have a chance of picking up some antibody after late in the stage of the disease, in my opinion, I think it's a GAD antibody. Velu, am I right?
No, the fact that she responded to oral agent again
Correct.
gives us some that this may not be purely a type
In
1.
fact, in the literature, there are some data. If you look at the type 1 diabetes mellitus, brittle diabetes. So, metformin is suggested as an add-on therapy for type 1 diabetic subjects to smoothen the control. This is there in the earlier books of pickup also, when there is a chapter on brittle diabetes. In other words, there has been attempts to introduce OHS even in the labeled type 1 diabetic subjects, but with respect to the consensus opinion, what is the prevailing treatment, I think excepting for the alpha glucosidase inhibitors, we are too hesitant to introduce OHS when you entertain a clinical diagnosis of type 1 diabetic subject.
The alpha glucosidase inhibitors has been introduced even in DCCT, if I remember right, for type 1 diabetics to avoid nocturnal hypoglycemia. That's what has been reported. Only for nocturnal hypoglycemia, where they have to continue the same amount of insulin, but they are getting into nocturnal hypoglycemia. But at that time, we didn't have the analog insulins that much during that time. That's about 30 years ago. Now that problem will not be there because you asked for alpha glucosidase inhibitors.
So before we proceed further, I want the organizers, now it's 12:55, can we go on till 1:15 if the audience and the organizers are comfortable? Yes, sir. Is it okay? Yes, yes.
115.
Fine, 1:15? Yes. Okay.
Yeah.
Please go ahead.
So just to re-emphasize the point which Professor Venkatraman sir said, young patient having high blood sugar initially treated as type 1 diabetic and GAD was actually negative. Without looking into the C-peptide level, without knowing whether there is a good insulin reserve, starting an oral drug may not be advisable at that point of time. Maybe this patient would have responded well, but we cannot take it as a prototype and start oral drugs for this kind of a patient without looking into the C-peptide. So with this in background, C-peptide was looked for this patient. Patient had a very good C-peptide level. You can see it is the stimulated C-peptide is 7.86, which is well above the lower range, and you can see, and then the patient also, since there is a small itching in mind for Dr. Gori, because he was the one who treated this as a third doctor. So since there was some kind of a younger onset diabetes in the family with the grandparents as well as with the parents, so patient was subjected to genetic testing for MODY. But unfortunately, we couldn't pick up anything. All these genes were not positive, it was only negative. So, can you sum up and say what was the lessons learned from this patient?
Sir, what we
Yes.
learned this case with C-peptide normal, still we have a working diagnosis of type 1. With the C-peptide continue to be normal, are we justified in giving OHS to this patient or not? Or in case if there is a good control after giving OHS, so can we withdraw OHS at that point of time? Because the patient was responding.
Withdraw insulin.
So the patient was, no, OHS. So
You said
because we
good
have
control.
diagnosis is type 1.
With good control,
No, see-
With good control with OHS and insulin. Sir. So now can we so still our working diagnosis will be type 1. So when as a clinician we see, can we withdraw OHS at that point of time and put the patient only on aggressive basal cholesterol?
Having so much of C-peptide,
No,
you want to...
I wish there is some C-peptide value earlier as well. Whether they had a higher C-peptide at that time and then coming down, it can always come down over the time. Like, slow onset type 1 diabetes, Dr. Madhavan was also telling. Maybe, did you check again after a few months or something like that C-peptide again? Or
Two C-peptides we did, sir. Both the C-peptides were same. Two GAD antibodies we did. Both the GAD antibodies were negative.
no, how many years later, how many months later did you check
Sir, around same,
C-peptide?
sir, 6-7, sir. In January we did 2023, C-peptide was 6-7, and that time it was getting control, and after that it was very good control, HbA1c was achieved. So that time again we did the C-peptide just for follow-up. That C-peptide is the one which we projected in 2000.
Earlier C-peptide? 6
Same,
months
sir,
earlier?
around 6-7, sir.
That is very interesting.
Very interesting. I think before we proceed further in a lighter vein, both I think Gauri and Rajesh would have given us some easier cases for the they are testing the clinical expertise as well as of course, I think it's a food for thought. We have to accept the realities. Otherwise, I think both of them would have had clear-cut cases wherein we have the diagnosis of a young type 2 diabetic subject, a type 1 diabetic subject, a MODY, etc., etc. So this calls for discussion had it been like that, so that we have, I think the message that I think Gauri and Rajesh, plus of course with the approval of my fellow panelists are, so when you talk about an young onset diabetes, there are two aspects. So you have the four combinations. One is autoimmunity positive or negative, the next is beta cell reserve is absence or negative. So in both these two cases, the working diagnosis rules out probably a type 1 diabetic subject. That is from the point of view of semantics, if I could say so. You have to label. But from the point of view of management, a 13-year-old girl with HbA1c of 11, I think you'll probably, your focus will be to maximize insulin, probably take the help of OHA after explaining to the patient that this might help you to